Welcome to Final BDS Made Easy. Our question for today is describe smoking in etiopathogenesis of periodontal disease and response of periodontal therapy in smokers. Here is a table from Carranza highlighting the etiological factors and their impact on smoking. So first is microbiology. It has no effect on rate of plaque accumulation, but there is increase in colonization of shallow periodontal pockets by periodontal pathogens. There is also increase in levels of periodontal pathogens in deep periodontal pockets. Next etiological factor is immune inflammatory response. There is altered neutrophil chemotaxis, phagocytosis, and oxidative burst in smokers. There is increase in TNF alpha and prostaglandin E2 in gingival clavicular fluid. There is increase in neutrophil collagenase and elastase in gingival clavicular fluid. There is increased production of prostaglandins E2 by monocytes in response to lipopolysaccharides also in smokers. Then talking about physiology. There is decrease in gingival blood vessels with increased inflammation in patients who smoke. Then there is decrease in gingival clavicular fluid flow and bleeding on probing with increased inflammation. Then decrease in subgingival temperature and increase in time needed to recover from local anesthesia. So there's this another table in Carranza highlighting the effects of smoking on response to periodontal therapy. So in response to non-surgical therapy, smokers show decreased clinical response to root surface debridement, that is scaling and root planing, decreased reduction in pocket depth, decrease in clinical attachment gain levels. Also, there is overall decrease in negative impact of smoking with the increase in level of plaque control. Then, in response to surgical and implant therapy, smokers show decreased pocket depth reduction and decreased gain in clinical attachment levels after access flap surgery. There is increased deterioration of furcations after surgery. There is decreased gain in clinical attachment levels, decreased bone fill, increased recession, and increased membrane exposure after guided tissue regeneration. Also, there is decreased pocket depth reduction after bone graft procedures. There is increased risk for implant failure and peri-implantitis. Then, in response to maintenance care, smokers show increased pocket depth and attachment loss during the maintenance therapy. Also, there is increased disease recurrence in smokers. There is increased need for retreatment in smokers, and there is increased tooth loss in smokers after surgical therapy. Those two tables were sufficient if you want to write a 7-marker question, but if you want to write it in more detail, then here's more. Starting with the increased prevalence and severity, smoking increases the prevalence and severity of periodontal destruction, as we all know. Host bacterial interactions are altered, leading to more extensive periodontal breakdown. This imbalance may be due to changes in subgingival biofilm composition, host response, or both. Microbiology. Higher prevalence of pathogenic bacteria such as Echinella notatum, Fusobacterium nucleatum, Prevotella intermedia, Peptostreptococcus micros, Prevotella nigrescens, Tannerella forsythia, Porphyromonas gingivalis, Treponema denticola in smokers. Increased colonization in shallow sites, that is of pocket depth less than or equal to 4 mm in smokers can be seen. Then smoking affects the immune inflammatory response leading to increased periodontal destruction. Neutrophils show functional alterations in chemotaxis, phagocytosis, and oxidative burst in smokers. Smokers have reduced levels of antibodies essential for phagocytosis and bacterial killing. Elevated levels of tumor necrosis factor alpha, prostaglandin E2, neutrophil elastase, and matrix metalloproteinase 8 in smokers. Increased release of tissue destructive enzymes causes increased periodontal tissue breakdown. Then, clinical signs of inflammation like gingival redness, gingival bleeding are less pronounced in smokers. Alterations in the vascular response of gingival tissues can be seen in smokers. There is lower oxygen concentration and subgingival temperatures in smokers. Smokers take longer recovery from vasoconstriction caused by local anesthetic administration. Such patients need to be warned about transient increase in gingival bleeding when quitting smoking. Then, effects of smoking on response to periodontal therapy. So, in response to non-surgical therapy, smokers do not respond as well to non-surgical periodontal therapy compared to non-smokers or former smokers. Greater probing depth reductions and clinical attachment gains in non-smokers. Excellent plaque control can minimize differences in treatment outcomes. Then, in response to surgical therapy and implants, smokers show less favorable response to surgical therapy like root planing, Widman flap surgery, and osseous resection surgery. There is less pocket reduction and clinical attachment gain in smokers even after 7 years of supportive periodontal therapy. Smokers have worse outcomes in guided tissue regeneration and bone graft procedures. Smoking increases risk of implant failure and peri-implantitis. There is long-lasting detrimental effect of smoking on treatment outcomes independent of maintenance therapy frequency. Smokers have deeper pockets and less attachment gain even with intensive maintenance therapy. Higher risk of tooth loss and peri-implant bone loss in smokers emphasize the need for smoking cessation counseling. Thank you for watching. If you like this video, hit the like button and subscribe to my YouTube channel for regular updates of more such videos. Stay tuned.